Well, as a patient, I think I'd like for my providers to recognize my personal goals, because I don't think my goals are always the goals of the institution, or maybe not at that time, at that place. I'm also a nurse. I've been a nurse for many, many years and have done nursing at many different levels, including home care and nursing research and such. And so I found that patients' values and goals need to really be included in, they need to be a part of the conversation. They need to be the focus of the conversation, not just what the institutional goals are. As a community health nurse or home care nurse, I have worked with immigrants around the issue of diabetes and diabetes education and such. And I found some interesting things. First of all, everyone has the same goals, and those goals are to meet their own personal goals. And so once again, I think what's important is that we establish what the patient's goals are. So sometimes our goals are about LDLs and A1Cs, and their goals are about seeing their granddaughter graduate from high school or their daughter get married. And so if you want to get to those, I think we need to marry the goals and let the patient's desires to meet their own goals guide what we provide for them. And we should provide assistance and not the roadmap itself.
All right, question number 3. Please share one example from a recent office experience that went well and felt good for you.
Well, I really didn't work so much in outpatient clinics as a nurse. I did home care, and my basic background is in critical care and finding the effects, living or dealing with people with the effects of long-term chronic disease. So I worked in CCU and medical ICU and stuff like that. But I did do a bit of home care and things that I have some experiences where patients that have had lots of interaction with the system and not work. For example, I was sent to see a patient who had 6, I believe it was, diabetes education courses, Ethiopian, Somali, I don't remember which actually, and she was Somali actually, patient who had 6 diabetes education classes and was still claiming not to understand and had values that were still off the chart. And so when we talked about what her goals were, and they were to see her granddaughter graduate from high school in America and whatever. And we also talked about what she thought was the reason for her high numbers on her blood sugars. And she didn't get that high blood sugars had anything to do with eyesight and all of those other kinds of things that aren't very obvious when you have diabetes. So we, talked about the relationship of being able to see with 500 blood sugars, in the very near future when they were that high. And it was still kind of difficult to bring it around, but what I did was use the example of like sugar in honey that in a bottle that turns to sugar, and how it gets thick and it turns to sugar and gets solid, and how that blocks off the transport of oxygen and all of that. And I put a rubber band on her finger so that she could feel how it turned blue and what blocking off meant and seemed. And then we talked about people from back home who didn't have legs or were blind, young people, and what did she think that was caused by. And the bottom line of the whole thing is that I found that they really had no concept of chronic illness and personally intervening on your own behalf to redirect chronic illness. So that was very enlightening for me because I had not considered that before, but really in this country we don't have much of a concept of chronic illness. We act all high and mighty about it, but you know, when was insulin and all of that discovered and refined, and we didn't have penicillin until 1943, and so we don't have really much of a concept of it ourselves. So it really made me much less, I guess authoritative is the word that I would use. It made me, it was a reality check for me, is that, you know, you're not all that just because you got this little thing that you've had. I mean, I remember as a student nurse, we were just learning about some of the basics of insulin, and new insulins were being developed every year or two. So anyway, listening to patients and finding out what their goals are and how they want to go about addressing them. And what happened, fortunately, was we talked about exactly what things affected, what she, you know, things they ate and exercise and how that affected her eyesight. She changed her behavior, and in 4 months, we majorly improved her A1C through Ramadan. We went through Ramadan even doing that, so it was a major undertaking. So she was Ethiopian. I think we could improve the care we give if we changed the paradigm that we work in. I think we're still working in an acute care paradigm where if it's broken, we can fix it there. It's mechanistic. There is a reason for everything, and if we work long enough and hard enough, we'll find the reason, and then we can fix the reason, and then you're all better. And I think that chronic illness is more probabilistic, that the patient really has to figure it out, and they have to tell us how we can help them. And if we don't do it that way, we can keep doing it the other way, and we're going to keep bringing them stuff and having big fancy programs that nobody shows up for, because it's not really what they're looking for. And I think that's going to be a real difficult shift to make because of how it ties to revenue. You know, the fee-for-service thing is just not conducive in that paradigm. So, how could things be better or improved? We need to change the whole paradigm of healthcare and and work out of a chronic illness paradigm where people identify what their issues are, what they want to change, what goals they want to meet, and then with the limited time we have to interact with them, we can figure out how we can assist them in meeting their own goals. Chronic illness is a community issue. It's something that the community has. It's like smoking. Nothing really is going to happen with, well, it really happened with smoking until we said, wait a minute, you can't smoke in my space, and you can't smoke in my house, and you can't smoke in my car, and until we started to get that. And still it's an uphill struggle, but at least there's a standard out there now that, you know, people can bring forth. Someone told me that new physicians in primary care at a clinic somewhere, they were doing data, collecting data, that new physicians expected to see 32 patients a day. And, I mean, come on. You can't do that in chronic illness. So I think that first of all has to be left to a team, that the team should include someone who is connected to that person, to that community, someone that they can relate to. And I really think that tape recordings are an ideal situation, an ideal thing to use. I can't remember what the doctor told me when I get home, and I've been a nurse for nearly 40 years, so I think for patients to be able to listen to what was said when they get home, to play that for their family members, to particularly when you're translating things. Lots of things don't translate, so they may have family members who speak English well and, can get different translations out of things that, so we don't really know how things are being translated, so I think that's a big issue. But they can review, and they can see what promises they made, because I think they do understand more than they say they understand when they come back for a new visit and it turns out that they haven't, their numbers aren't better. Well, what do you say? Oh, well, I didn't know I was supposed to do that, when if they have it on tape for themselves. So I don't necessarily, I suppose the tapes would have to be a part of their medical records because it would, but that's not necessarily so. I know consultants who let patients tape their consult and take it home, so they don't call them up and ask them every 5 minutes what they said. So I think that would be really how would I change the system? I would tape, with permission, give people their tapes, whatever, as much as possible of teaching and education for people to take home and of themselves, making tapes for them to view. But when they see themselves saying, oh yeah, I understand now. Well, what did you say? Oh yeah, I understand now. Then I think that would make a difference. The other thing I think is important is checking people's depression scale. There's a PHQ-9, which is a commonly used scale, and no more so in Minnesota. They really have done some research around that, and I think that lots of people of color, people whose life is lived at a higher stress level, and some even higher, their depression level needs to be assessed, because you can't even set a goal if you're depressed. And if depression is the common cold of psychiatry, and chronic illness is a very good reason to be depressed, then most people with chronic illness should have depression to a greater level than the general population. And then when you add in the disparate conditions of people of color, again, that would be more likely. So I think assessing depression levels before you attempt to set goals, and then having people to identify their goals and ask you to help them, asking you for specific help to meet them, is so much more efficient than us coming up with big programs and then trying to make those programs fit people by population groups. By definition, chronic illness cannot be cured. So a cure model where you break it, you bring it in here, we can fix it. Oh, so you have something else wrong this week? Let me see what else I can give you. By definition, that can't work. It just doesn't make sense. So not only that, the discussions that it takes to address chronic illness don't, they're not revenue producing. And we have a fee-for-service revenue producing system. So you've got to get the people working themselves, and they've got to be motivated. And the only way to motivate somebody is to meet their own goals, not LDL or A1C. It's got to be about not being impotent. That's a real good motivator for a lot of folks. You know, seeing my child graduate from high school, since, you know, things about your eyesight may not be noticeable for years, but, you know, when you can show them, if they, oh, this is not going to bother my eyesight, when you can show them exactly how it does, and you know, indeed, you may not be able to see in 15 years. So I think that it's real important to look at it that way, but it's so politically incorrect. We call it blaming the victim when we talk about people having personal responsibility. And we don't want to be politically incorrect. We want to assure people that we're helping them, and that we want to help them, and that we want to do for them. But you just can't do it. You can't do, these are things you can't do. And the more you try to do for them and not have them assume that responsibility, the worse the situation gets. And it's already at, I think it's outrageous. It's at dire, we're at dire states at this point, with so much. And that whole thing about immigrants really not getting this chronic illness thing, I think that's really an important piece to get, that they don't get it. And, you know, we don't need to get so cocky, because we didn't get it either 50 years ago, which is, by the way, in my lifetime. Education does not change behavior. That's something that I just think slips by so many people. I was a nurse in the 80s. I got my master's back in the 80s. That's what we were going to do, was educate people. Patient education, that's where all that patient education, when it all started back in the mid-80s. We were going to educate people, and this chronic illness was going to be gone. Well, it doesn't. Education does not change behavior. You can't change behavior if you don't know what to change it to, so you do need education. But because you're educated, it does not change behavior. If it did, there would be nobody smoking. We've had no smoking on cigarette packs and education around that since 1965. So there's something else that has to motivate you. And so we need to get beyond, all we need to do is come up with a new education program. Personal goals aren't necessarily intellectually conceived. So, you know, it may be emotional. People don't bring up everything, but that's why you have to put it in their lap, because you don't know why they're not doing. You know, you're intelligent, you understand smoking. I mean, we had people present that were part of the community that are involved in this program, talking about how they changed doctors every time they tried to tell them something about their diabetes. They would go to a different doctor. And someone else say they were more than 100 pounds overweight and didn't want the doctor to tell them anything about weight loss and the importance of it, and so they would go to a different doctor or whatever. So, yeah, it's not about your weight. You can weigh whatever you want to weigh, but let me talk to you about how long you can live, or what the data says about you living, and the quality of life that you're most likely to have if you're 100 pounds overweight. So, you know, if you want to keep on doing that, doing what you're doing, then do that, because we do have to weigh everything. And even any med that you give, a Tylenol, I mean, anything that you take has a risk benefit to it. But in chronic illness, the patient has to weigh the risk and benefits for themselves. You can't weigh them. So, you know, I wouldn't participate in an Olympic winter sport or what is that, crash thing they have in St. Paul right now. I mean, that's more dangerous than anything anybody we know is going to eat. But we value things different ways. You know, it's okay for you to put your life at risk to skydive or ride a motorcycle or whatever. And, you know, so as a society, we value things in different ways. And we need to understand that people as individuals value things in different ways. You know, running a marathon until your legs fall off and you die, to me, that's crazy. I'd rather eat cheesecake and jeopardize my life in that way, or fried chicken and jeopardize my life in that way. You know, so we really need to look at how, as a society, we have structural things that we have ways of valuing behaviors, and that what we don't think is appropriate may be very appropriate if you put it in that kind of context. I mean, really, riding down that ice thing in St. Paul, eating fried chicken and cheesecake. I mean, both of them are likely to kill you. It's just a matter of making a choice of which risk you want to take.